Welcome, Hazel and Anna, to today's International Women's Day podcast. It's such an honor to have you both on, and I'm really looking forward to this discussion. Let's start with Anna. Won't you just take a moment to introduce yourself a little bit?
Hi, yeah, I'm Anna, and I have a background in, I'm so excited to be here. I have a background in women's health, having worked in the field for all of my career in the past 12 years. I started studying in the US in public health, and I worked on two programs there, one working with people who have HIV, and the other on an international program looking at vaccines, mostly in Uganda and Mozambique, on the maternal and child survival program, and doing that with midwives and other health professionals in women's health, and was inspired myself to become a midwife. So I moved to the United Kingdom and have been a midwife for the past 5 years. And most recently, in this past year, I'm also pursuing a master's in global health, social justice, and public policy. So all of my experience really ties to women's health, and it's something I'm really passionate about.
Thank you so much, Anna. Hazel.
Hi, everyone. My name is Hazel, and I'm a doctoral graduate in human rights law. I specifically did my research and specialize in women's rights from a post-colonial as well as a social legal perspective, and I've focused specifically on violence against women and how, despite there being a lot of laws that try to protect women and aim to protect women, there is still a lot more violence than there are laws or cases or solutions to violence against women. And that's what I've been working towards. Beyond that, I think I really focus my research and my passions on spreading awareness and building opportunities for women. And I try to have that infiltrate everything that I participate in or that I am a part of. And that's what also has been part of my intersection with health diplomats and with tobacco harm reduction. I think tobacco harm reduction is such an amazing tool for women to be given and people to be given more options in their choices towards a healthier future.
I would like to start by asking Anna, you've worked in both global vaccination programs and clinical midwifery. What has working directly with women taught you that policy spaces often overlook?
Yeah, so I think working with women, you very quickly realize that a lot of the policies and the research is not necessarily built on women's experiences. Unfortunately, women are massively underrepresented in medical studies, mostly because of the complex nature of women's health. There's a lot we don't know about hormonal health, and a lot of studies are put off using women because of their perceived vulnerable nature, being the child bearers in society. So that just means that we don't know a lot in terms of medical research, but even still, a lot of funding is not directed towards women's health research. So policy, I feel, often misses a lot of the key aspects of women's health just purely because they're understudied.
Thank you, Anna. So, and Hazel, you specialize in post-colonial and socio-legal approaches to violence against women. Why is it dangerous to assume that there is one universal solution to women's health rights issues?
That's a really good question, Ilna. And I think originally that was the approach that women's rights movement took as well, that there is one goal that we should all be working towards, and was, for the first wave, it was suffrage, universal voting for women. However, women quickly came to realize that having that singular approach or universal approach just ostracizes women who lie in the intersections of society, whether that be with race or religion or cultural elements or sexual orientation or other factors as well, because it excludes their realities and excludes what they might be looking for or what they might be struggling with in their lives. For example, I'm from India, and looking at the women's rights movement from a Western lens and from an Indian or post-colonial lens, the things that we're fighting for may look very similar, but also very different when it comes to the education level that's still quite low in India for women, or the workforce integration that is still lacking. So that's why it can be quite dangerous to look at women's rights as one universal entity without differentiation within.
And you've spoken about the importance of giving women understandable information. In your experience, what happens when women truly understand their health choices?
So I think giving women understandable, useful information is honestly the best way to empower them in their health choices. Fostering that true understanding regarding their health is the surest path to them being healthy, being happy, and feeling empowered. And when women have that power, I feel like to make their own health decisions, I feel like they can't go wrong. So in most cases, they know what's best for themselves. But even if they go against, for example, what a protocol or what a guideline says, I feel they're always happy with their decision as long as they feel they had all the information to make that decision.
Amazing. And Hazel, you've also said that knowledge can be wielded as both empowerment and oppression. Can you explain how lack of access to information becomes a tool of control?
Yes, absolutely. And actually, I have a real world example that might showcase how coercive or how harmful the lack of knowledge can be and how it can be used as a tool. I'm part of a group here where I live. It's a support group for women facing abuse, and I volunteer with them. And in our most recent discussion that we had, there was somebody who talked about the abuse she's facing from her partner, from her husband, and went on to say that after a particularly violent case where there was physical evidence of the abuse, she went to the cops to report it, and she wanted to turn it into a case, but the police said, oh, if you do make it a case, you'll have to run around the courts and you're going to have to spend a lot of money and it's going to be very bureaucratic. It's going to take years out of your life and it's just going to be too much of a hassle for you. Better for your own sake, you don't report it. We'll talk to your husband. We'll tell him to stop doing this. And she didn't know better. And she saw the police as a figure of authority and acquiesced to what they told her and the knowledge that they gave her. However, in reality, it's very clearly laid out in Indian laws that reporting is to be made as easy as possible. There is to be no coercion, absolutely, against reporting. If anything, there should be promotion of reporting in police spaces. Moreover, there's also laws and provisions that support women in their court cases so that there isn't a lot of running around, there isn't a lot of expenses, there isn't a lot of bureaucracy. But she was completely denied this information and was told opposing information that prevented her from reporting when she could have, and she's faced more severe abuse since. So, and part of where this comes from and why it was told this way is the social element of the social legal analysis that we do, is that even though the laws exist, society has certain constructs about how a woman should submit to her husband or what is or isn't acceptable within a marriage when it comes to violence. And those often are enforced by police officers or court systems because they are individuals themselves and individuals who are part of this patriarchal system themselves. So that's an example of how harmful it can be and how real it can be, that the lack of knowledge or knowledge wielded in a way that excludes women can harm women.
So unfortunately, it is a cycle that without metrics to display a certain outcome, there tends to be little investment and progress towards addressing said outcome. So what that means for women's health is that we focus on aspects that are easy to measure or achieve. And that does not always correlate to what women's health needs or what women need out of the system. So women being largely ignored in the field of research, it kind of continues this cycle where we won't be getting the outcomes or the research that we need to truly address the health needs that women are facing. When we look at industries trying to fight this, such as femtech, which is an industry focusing on women's health technology, it largely focuses on technology that are easy to measure or easy to produce and not necessarily technology that's addressing a need. So I think that, that it just causes the cycle where we're not necessarily understanding what we truly need to be researching and what we truly need from women's health, because we're so focused on kind of what's lucrative and what drives funding, and what we can measure and prove that we're improving.
Absolutely. And while all that's happening, people who really need the help are falling through the cracks as the system tries to figure out where to allocate the funding. And Hazel, in cases of domestic violence, criminalization is often seen as the only solution, a primary solution. Why can this sometimes fail women in practice?
Yeah, I think that's a really important question, but something that I also struggle with growing up, as criminalization being the right solution, right? You know, when you hear of, like the case I mentioned, when you hear of abuse, you say, oh, that person needs to go to jail, and that's so thought of as the automatic solution. But post-colonial literature, post-colonial feminist literature really talks about looking at alternatives in order to cater to the person who's affected by the abuse, which is the woman. Because again, speaking of India as my context and my area of expertise, but also other countries in South Asia and other communities around the world, a lot of times the reality of women is that they may live in a joint family, which is their husband's family. They may also not be the sole providers or the providers in their household. The husband may be the sole provider in their household. And they may also live in a culture that prioritizes family reputation, the dignity of the family. So when all these circumstances or a combination of these circumstances are combined and a woman faces abuse and she reports that abuse, having that lead to criminalization may have her face the biggest repercussions, because she may no longer have a marital home to go to. She may no longer have her natal home, her parents' home to go back to, because of it might be seen as disrespectful, or it might be seen as a shameful thing that she reported her husband or spoke up against her family. And she may no longer have financial support in order to provide for herself and or her children. And these factors are just a few of what prevent women from reporting abuse when they think criminalization is what it would lead to. Instead of that, for example, in India, there's also civil procedures against domestic violence. And there are provisions such as having an order that says that a woman cannot leave her marital home, that she has the right to reside in her marital home when she reports abuse. So things like that are small steps that may look counter to what criminalization or what traditional measures say is progress, but can really help in the lived realities of women in places like India.
Wow, it's supporting women in the real situation, even when there are laws that technically provide and have provision for that. So Anna, midwifery is about support and not fixing. And what lessons can broader public health learn from that model of care? And also what is actually implied when you say you're there to support and not to fix?
Yeah, so midwifery is, supporting a woman through arguably the most important time of her and her family's life. And pregnancy is not something like other medical field that needs to be fixed. It is just a very natural process that needs to be supported. And so I think we have a unique opportunity in that time frame to really support families where they are. And in terms of public health, that means kind of giving them the right resources to be successful, and really helping them to better their health if that's what they need. But like you said, it's not about fixing problems, it's just about support. And a big lesson to learn from that is also in harm reduction. A lot of pregnancy care is seen as harm reduction. It's not telling someone to not do something. It's kind of showing them how to do it safely, or changing it slightly, and meeting people where they are. And so that can foster better health outcomes. And I think in that way, maternity care or pregnancy care, if it's done correctly via midwifery and women-centered care, can teach us a lot in terms of public health and how we can support individuals with their health.
Thank you, Anna. And Hazel, how important is it to center women's own agency when designing policy responses, whether in law or in public health?
Yeah, I think it's very important, because women themselves are the only ones who can speak to their lived experiences, their on-ground realities. And here it's not important to just have women as representation, because thankfully over the years and through efforts in events and organizations such as Women's Day and Women's Day Month, Women's Month, I think we have made a lot of progress in female representation, which is great. But I think the next step now, and a very important step, is again the intersectionality of that representation, having a woman or a group of women from similar socioeconomic statuses, similar education levels, similar lived experiences speak to certain public health policies is great, but that does not account for the experiences of different groups of women, different communities of women who have different realities. And with that, we let the most vulnerable slip through the cracks, as we were mentioning with funding as well earlier in this conversation. So it's really important to have consultations with women from different stratas of society before embarking on laws and before embarking on public health policies, and then checking in with them after as well, to know what kind of restrictions they have in terms of perhaps caretaking or mobility, perhaps there's cultural expectations around where they can or cannot go, perhaps there's spaces where they can only interact with other females, and making sure those provisions are there in healthcare organizations or in places that are meant to help women. These little things are really important and make all the difference, and we won't know it unless we ask women themselves.
This year's theme is Give to Gain. In the context of women's health, what do we gain when we prioritize empathy?
So I think, like what Hazel was saying, it's really important to include all voices and to really understand the nuance of individualized experience, and that women all come into pregnancy with different circumstances, different experiences, and it's not fair to just give generalized care. So giving empathy allows you to give an individualized approach. And by giving empathy, we can really gain women's trust. And as health professionals, that is the key to really providing good care, because with trust comes them trusting what you're suggesting, them trusting you with information that might be helpful to supporting them. So by giving empathy, we gain that trust, and we have the potential to really prioritize women in their health and to help them with their health.
It's like giving them a voice,
Exactly.
And I actually want to ask Hazel, what does give a voice to gain change? I know that that's one of the themes for this year's International Women's Day. What does that mean in practical terms for women who feel unheard?
I completely agree with what Anna said, and just adding on to that as well, I think give a voice to gain change, or just giving a voice, is so important on both a structural level and a personal level. And I think the personal level applies in practical terms for both, right? But when we talk about a structural level, I think throughout history, we see so many examples of decisions being made about women and for women without women. And the fact that we see that changing now is something we really need to hold on to and make sure that that reflects all sectors of society. And specifically that it doesn't just reflect women's issues, but anything, because as half of the population, we need our say in any sort of legislation or law or public health policy that's happening and that's going to be out there. But on a personal level, and what does that actually mean for change? I'll go back to the support group that I'm a part of again. Just firstly, seeing women sharing their stories, sharing their reality. It's so powerful when a lot of times women are kept in a space where they aren't able to share because they're living with the perpetrator, or they're living in a society where it's expected of them to endure it. I think another social element of the social legal aspects of the situation that women face is that there's a element of protecting what's happening in the household. You know, what happens here stays here. You shouldn't sully the name of the house further out. So a lot of women feel like they can't share what they're going through, and perhaps how they feel about what they're going through is not valid. And this doesn't even have to be just in terms of violence, but even with healthcare issues, a lot of reproductive issues that women face. Perhaps they're told just to bear the pain, or that there's nothing wrong, nothing that's happening to them. So just sharing in a space and talking and giving voice to their feelings is such a powerful tool, and it really makes a difference. I've seen how it makes a difference for the women in the support group, wherein just to be able to let it out and have people nod along, that just makes such a big difference. And then it's also what that translates into, because with the example I gave earlier of the woman who went to the police station, now there's people who can tell her, hey, actually they were wrong and you were right. And okay, you're worried about the costs. Well, here are some organizations that can help cover it entirely for you on the government's expense. Or are you worried about your children? Well, we can help them get admission into these schools, which will help them have a roof over their head while all this is going on at home, right? So just sharing it with others helps share the burden and helps women and men support women as they go through these struggles.
It's so poignant as well in maternity care. You know, Anna, you focus on empowering women with clear, understandable information. And how would the same principle apply? We've been talking about harm reduction, and what Hazel said is so true and beautiful in terms of allocating resources that empower change, and it empowers safety in the lives of women who, like Hazel says, like have the realities that they live are incredibly different to what we can even fathom in the West. And I think the way that the social structures within those communities are actually put together, you can't, from a point of view of someone who got raised in a Christian home, you know, you had friends to go around to, you had a stable home environment for the most part. Even if your parents divorced, it was very hush hush, but it didn't break families apart the way that it does in the parts of these worlds. So when you focus on empowering women with clear, understandable information, how does that same principle apply when discussing tobacco harm reduction and smoking cessation with women?
Yeah, so smoking cessation is obviously a really interesting topic in pregnancy, because I find that most women do understand the harms of smoking. So there's really no point in judging or in having kind of any shame in presenting that information, because women, most of them know that smoking is harmful in pregnancy. So if they're smoking in pregnancy, it's most likely due to just the lack of ability to quit, which is a very understandable thing for a lot of women, especially if there's other things going on, other stressors in their life, or just the lack of knowledge around the support for quitting. So I think in terms of harm reduction and tobacco during pregnancy, it's really important not to have that judgment and not to kind of have them feeling that shame, because similar to what Hazel was saying about, you know, them coming forward and giving the right information, I think if you give them the information on different techniques rather than just saying, oh, no, you shouldn't be smoking, and you're giving them, you know, tools to stop smoking or support, that's when they're going to be most successful. So there's really no point in this all or nothing approach. It's really harm reduction. We do in so many other parts of pregnancy care, and tobacco should continue to be the same, because we know that kind of alternatives to cigarette smoking can be so much less harmful to the woman and the baby. So it's really just about empowering her with that knowledge and those tools, rather than giving this like all or nothing approach that she probably already knows about.
Yes, and from a rights-based perspective, Hazel, how important is it that women have access to the full spectrum of health information, including harm reduction options, rather than being told what choices to make?
Absolutely. I think I completely agree with everything Anna said, and I think that applies very well to women in pregnancy, but also women in general as well. And I think a big element that you touched upon, Anna, is this element of shame. And I think that gets in the way, not only in certain societies or more cultural or conservative societies, but all over the world. I think that gets in the way of making tangible change. From a rights-based perspective, it's so important that women are given full reign of their choices and just given full agency and trust that they will make the decisions with that agency that they know is best for them given their realities, right? So it's really important. And when it comes to different communities, different cultures, it's also important that this information is given in actually understandable ways to these women, whether that's different languages, whether that's by relating them to, like, using an analogy that is understandable, or whether that's having honest discussions among women, just talking about it within women themselves in order to bring out in the open something that women might even hesitate to discuss because of the shame associated with it or the taboo associated with it. And just making sure that there are varied ways in which this information and access to alternative products are reaching women and meeting them where they're at is so important from a rights-based perspective. Yes.
That's incredible. And women who often face additional stigma around smoking, besides the social factor, particularly during pregnancy or motherhood, how can harm reduction approach reflect empathy rather than judgment in these situations?
So definitely, I think harm reduction is rooted in empathy because it is approaching and meeting the women where they are. And in pregnancy, like I said, with most women, they know the risks associated with the behaviors that they're engaging in. And there's some other factors going on that are affecting their ability to stop those behaviors. And as midwives, it really isn't our place to judge, to judge those behaviors or why they're doing them, but rather to approach it with empathy, to try to understand and gain trust, like I said, and to try to understand what would be helpful to them. Because we know with harm reduction, especially smoking or tobacco harm reduction, that switching to alternatives, can have a 95% reduction in harm, which is so significant that it would be silly to tell a woman, oh, you have to quit, when she could do this alternative that might be easier for her and have so much more and have so much of the benefit. In a time where women already feel the stigma that they're smoking and they know that it's harmful, I think giving them those options and informing them that they are significantly less harmful can really be like a bridge for them to crossing into the cessation, but also feeling less stigmatized. A lot of the harm reduction approaches in tobacco are less visible. And I think for pregnant women, kind of visibility around smoking is probably where they feel, they might feel that people are judging them. So knowing that there's options that they can engage with that might be less visible, or just knowing in themselves that it's less harmful, would help to support them.
Beautifully said, Anna. And Hazel, we often see that health policies are designed without considering how stigma affects women differently. How can gender-sensitive tobacco harm reduction policies better reflect women's lived realities?
That's a very good question. I think earlier when we were talking, Anna had mentioned about the lack of metrics and how the lack of metrics affects the investment that goes into women's health. And I think that's such a real experience for stigma as well. It's so hard to measure stigma in the kind of metrics that health organizations still prioritize. So it's very important for us to look at gender sensitive policies and look at how do we measure this differently? How do we take different elements into consideration when creating gender sensitive policies? I think a couple actions that feel more tangible that we can take is making sure that there are consultations before any policy is implemented, and those consultations have women in mind. And for advocacy organizations or people involved in promoting policies who may be listening or who may be influenced by this, they can be part of those consultations, of making sure that they can do the work a little bit beforehand for the government, so the governments are more likely to take this into account, makes a big difference. And just as an example, tobaccoharmreduction.net recently released a report about oral nicotine pouches in Sweden. And there was clear evidence there about how Swedish women did prefer oral nicotine pouches for varied reasons, including, as Anna said, sort of the discretion element of it. In fact, I think one of the quotes in that report mentions how the woman is around her children, so she prefers something that's a little more discreet. And it's wonderful to be able to cater to that while still reducing harm by, again, more than 90% and more than 95% in cases, right? So making sure that there's multifaceted benefits of products for women is a big element to gender sensitive policy as well. Another thing that's very important with making sure that there's effective gender sensitive policy is including women in the policy making conversation, not just the consultation. So making sure that we have women at the table, have women's voices heard, and again, the intersectionality element, and making sure having women from different stratas of society, however we want to see those divisions, is a great way to make sure the policy is effective and not just something that's there to check a box and then move on.
I have one follow-up question, Hazel. As far as actionable intent goes among the public, what can we do to kind of like stoke the fire a little bit in the sense of getting policymakers to pay attention to this?
That's a really good question. I think a wonderful thing that we can do ourselves is when we hear about a bill being passed or a policy being passed or being discussed that may limit the options of women, whether it's in tobacco harm reduction or in other elements of life, there's almost always a way for us to reach out to the people who are in the committee of this bill and share our opinion with them. Sometimes it's done with public campaigns, people gathering signatures and then sharing to say, see, look, there's these many people who think differently. And sometimes it's done by being part of an organization or even an individual and emailing the contact that's provided and sharing with them. Another way is for those who feel comfortable and safe enough to do it is just to share your own experiences, write them on a blog, post them on Facebook, put them in our comments. And this is just a great way for it to be more visible, more seen that, hey, there are women who are asking for this or who prefer that or who would like to know more about this option. And the more we see that in reality, the more we can embrace it and more people can speak out and we can work towards actionable change.
Thank you, Hazel. And I wanted to just also know from your perspective, as far as supporting midwives in, having responsible conversations about patients' health and their risk alternatives, lower risk alternatives goes, is there a way we can help empower midwives to have this conversation more effectively?
Yeah, so I think midwives, they are stretched in terms of the system and wanting to address so many different aspects of care. But I think knowledge empowerment is really key in terms of, when we talk about specifically tobacco harm reduction. I know midwives are often we're the referrers, right? We refer to services, but a lot of times knowing that information can help you convince the woman to accept the referral. So I think kind of empowering midwives with the most up-to-date information can really help them to support women and to help, get them to the services that they need by just having a little bit more information on what the service might provide or help them with.
Thank you, ladies, so much for today. It was really so special having you both. And I love listening to both sides of this, and it really gives you a more expanded view on the situation and where we can really fill in the gaps and where we can pull focus as together as women. Because if it's not us, who's it going to be?
Exactly. Thank you.